So over to Dr. Lipika for PCOS session. I'll just like to introduce her. I'm sure all of you know her quite well, but she is a brilliant student. She was MBBS-based graduate and state topper in her medical college in Odisha. She has a done fellowship in reproductive medicine, clinical embryology, and ultrasound. She has a diploma in sexual health and self-fertility. She is a managing committee member of ISAR Odisha and a member of Young Brigade of ISAR. There are so many things to her credit, so I'll go a little slow. She has got National ISAR SIG Sexual Medicine membership. She is the East Zone Coordinator of Foxy Young Talent Promotion Committee, the member of Foxy Sexual Medicine Committee. He is a member of Managing Committee of PCOS Society of India. She was awarded the Youth Icon by ISAR in 2023. And she has contributed chapters in various books of infertility as well as in books of sexual medicine. And she was the convener of National ISAR Gurukul program. And she's an invited faculty in almost all the conferences which happen in India and Southeast Asia. And she is a trainer in Fertilis Sadbhavna Academy, as all of you know. Also, she's an editor in a National IVF newsletter. He's a life member in Foxy, ISAR, IFS, PCOS Society of India, and FPSI. So with this brief introduction, Dr. Lipika, I hand over the mic to you. And thank you so much for patient listening. Dr. Lipika,
Thank
you
you
can
so
share
much,
the
sir.
screen now.
Thank you for your kind words of introduction. On behalf of Fertilis Academy, I welcome you all again to this demo course. So we feel fortunate to have planned such a comprehensive course on IVF from basic to advanced. So our purpose of these demo classes is just to, increase interest within you so that you feel interested and, you improve your IVF practice. So this will be a topic which is very, very close to my heart. I've been training multiple doctors on PCOS. So I'll just, this demo session will also be, I'll touch glimpses of the session because all of it will be covered in details. Once we start the course, all of it will be covered and taken up in further details. But today I'll have to complete the course demo session on time. And once you all register for the course, you'll be getting the recordings of this session as well. So you can take pictures of slides if you need. Otherwise, the recording will be shared with all of you. So I'll start the session without delay. I'll just share my screen. I hope my voice is clear. And if any questions, you can post it in between in the chat box. I'll go through the chat box or we can discuss your questions at the end of the session. So basically, the talk will be focused on the guidelines and recommendations of the art of assisted reproductive techniques in PCO. But I will start with basics so that understanding pathophysiology will help you understand how do we approach a case in PCOS. So this will be the outlines of the session today. All of it will be covered in much more details once the course commences. So what I call PCO is the Pandora's box. It is a box full of mystery. The more you learn about it, the more you get confused and more you get interested in learning more about it. So I will start with Einstein's famous quote which says that if you can't explain something simply, you haven't understood it well enough. So I'll try to make PCOS, this complex syndrome, this mystery syndrome, as simple as possible for you and give you some clinical practice points which will help you in dealing with your cases in OPD. So to introduce, this syndrome affects around 6 to 10% of women of reproductive age. However, I would say it affects around 30 to 40% of Indian women, what we see in clinical practice. What is characteristic of this syndrome is the confusion associated with it. So there is a lot of confusion starting from defining the syndrome to the ultrasound morphology of the ovaries to the clinical findings of a woman with PCO. Right? So despite being one of the most common endocrinopathies of reproductive females, a clear comprehensive explanation of pathophysiology of this syndrome is still lacking. It is rational to consider this syndrome as a result of a vicious cycle. So you never know where the pathophysiology of the syndrome starts, but it can start in any point of the loop, and the rest of the loop can start continuing from that point. So the origin is unknown, but it can start from anywhere in the loop. I'll tell you what are the starting points of initiation of this complex syndrome. Altered function at any point in the cycle can lead to the same end result, that is ovarian androgen excess and anovulation. anovulation. So where we are considered with subfertility in the female related to PCO is ovarian androgen excess. So normally ovaries should be female hormone dominant. Therefore, estrogen should be dominant in the ovaries. However, if androgen becomes the predominant hormone in the ovarian stroma, it becomes in the female becomes subfertile, and therefore consequently she has anovulation and amenorrheic cycles. So what are the suggested theories? A unique defect in insulin action can start insulin action as well as secretion, which leads to hyperinsulinemia and insulin resistance. So there are multiple theories suggested for insulin resistance associated with this syndrome. There could be intrinsic beta cell. We all know that pancreas has a cell, alpha cell, beta cell. Beta cells secrete insulin. So there is an inherent defect in the beta cell from where insulin is released in more amount. That is one reason. The other reason is peripheral level insulin resistance. So the body feels that with the existing level of serum insulin, the insulin is not able to act in the body, and therefore more amount of insulin is secreted by the beta cells. So this is number one point of the loop of pathophysiology, insulin excess and hyperinsulinemia. The next thing is an idiopathic release of hypersecretion of LH. So LH is luteinizing hormone released from the pituitary. So we do not know the cause, but there is a significant hypersecretion of LH from the pituitary that leads to the downhill effects in PCOS. The third point is a defect in androgen secretion. So there is a lot of androgen, enhanced ovarian androgen synthesis from the theca cells. You all know that ovaries have two types of cells. One is granulosa cell, one is theca cell. So in PCOS, what happens? The theca cells hypersecrete insulin, hypersecrete androgens as a result of the insulin excess and LH excess. And the last is adrenal component attached with the syndrome. So there is an alteration in the cortisol metabolism associated with enhanced adrenal androgen production. So we can understand that all 3 or 4 of these points of the circuit are interrelated. So number 1 is hyperinsulinemia and insulin resistance. Number 2 is idiopathic hypersecretion of LH. Number 3 is enhanced ovarian androgen production. And number 4 is an alteration of the adrenal androgen excess. So these will be the 4 main points of the circuit. So this is all summed up here. One is increased GnRH pulses. So I'll tell you something which is very simple to understand and very basic to this syndrome. There are 2 kinds of hormone from the pituitary, 2 gonadotrophins. One is FSH, one is LH. So basically what happens, we know that gonadotrophin releasing hormone pulses are from the hypothalamus, which is uphill to the pituitary. So we get releasing hormones from the hypothalamus. However, you can see one word is written here, pulses. So pulses means frequency. The number of times GnRH is released, that is pulse, frequency. One is amplitude. So amplitude is how much of GnRH is released, right? So what happens is with increase in GnRH pulse frequency, that is the number of times GnRH is released, LH secretion predominates over FSH. So that is what happens in PCO. So there is a preferential increased release of LH compared to FSH in PCO females, right? The next is polycystic ovarian morphology. This happens because of anovulation. So normally a follicle should develop from different stages like primordial follicle, primary follicle, secondary follicle, Graafian follicle that will rupture releasing the egg. Then it becomes corpus luteum, right? So that is a normal. I have a clear picture in the pathophysiology segment where you will understand things more better. But what happens is once the egg doesn't mature in the way it should, the egg is not released. So all of the follicles gradually become cystic because they are not ruptured. So they accumulate follicular fluid and they become cystic. That is the reason for having polycystic ovaries on ultrasound. Next is anovulation and subfertility. So obviously because the egg is not released, the female will become subfertile, and insulin resistance and metabolic complications associated with insulin. So I'll tell you a very important thing. PCOS Society of India, we as the managing committee members, we have suggested a name change for the syndrome just to signify how important it is to look beyond the ovaries, because this is female metabolic syndrome. So all of the PCOS society across the globe have been asked for a name change because it's just not restricted to the ovaries. It is much beyond fertility and ovaries. Though the name which we have suggested is female metabolic syndrome. I always call this syndrome as a pre-diabetic state. So we all know that diabetic patients have a hyperinsulinemic state, right? So this syndrome is also related to insulin resistance and hyperinsulinemia, and the consequent metabolic effects of this syndrome. So this is a simple figure which shows the vicious cycle associated with this syndrome. So we start with sex hormone imbalance, that is androgen excess, more fat accumulation in the adipose tissue, insulin resistance resulting in high insulin levels, and consequent PCOS symptoms. So this is the vicious cycle which is associated with PCOS. This is again the same thing wherein you can see I have written a point VAT and FFA. So what is this? I'll tell you later on as we move across the slides. VAT is visceral adipose tissue. So just remember adipose tissue, fat tissue in the body, that is also an independent metabolic organ. So obesity we all know is strongly linked to PCOS. Therefore adipose tissue as such is a very, very significant organ, endocrine organ. So there are a lot of hormones secreted like adiponectins, leptins, all of which, like they induce our hunger and appetite, that is released from the adipose tissue. So VAT is visceral adipose tissue. Okay, there is one subcutaneous adipose tissue, which is the peripheral adipose tissue. There is one visceral adipose tissue, which is the internal organ surrounded by fat. So visceral adipose tissue is much, much more important for metabolic complications of PCO. So you can see that basically this is the vicious cycle associated with PCO. You can see the last lower figure as well. So there is increased visceral fat, excess androgen, excess insulin, and adipose tissue inflammation. Therefore, we can understand that PCO is a state of chronic inflammation. So wherever there are reactive oxygen species, there is more of inflammation in the body, there is more of oxidative stress in the body, and therefore the egg quality in PCO is bad. Okay, and that is also linked to obesity. So obesity and PCO both are chronic inflammatory conditions. Therefore, at times we need to give anti-inflammatory drugs when we do ovarian stimulation in PCO females. So what is the prevalence of this syndrome? It is rapidly increasing because when I started my practice in PCO 7 years back, around 7 to 8 years back, there were around 4 to 5 patients out of 20 patients were having PCO. But nowadays, I think it's almost 20 out of 20 patients having PCO. All right. So this could be the reasons for increased incidence of PCO. So we all know that these are the common causes of female infertility. However, ovulatory disorders form the bulk, and out of ovulatory disorders, PCO forms around 90% of ovulatory disorders in female infertility. Now we all know the origin of PCO. It is obviously the unhealthy lifestyle, the diet, lack of exercise, the electronic devices, the extent of electronic device use, the sedentary lifestyle, and the environmental toxins that we are exposed to. So, just to summarize, I've put the points, but we are all aware of the causes of PCO. So these are the common causes of PCO. So whenever you approach a case of PCO with any symptoms, it can be infertility, it can be simple symptoms, your role first is to induce lifestyle changes in the patient. Even if you're going for IVF stimulation, lifestyle changes form the cornerstone of getting good oocytes and good blasts in PCO. All right. So we move on to the etiologies. I will not go through the details because we have a lot of slides to cover. So we know that one important cause is prenatal exposure to androgen. When does this happen? This happens in the intrauterine environment of the mother. So when a pregnant lady carries a female fetus, she is exposed to more of androgens, more of carbohydrates, more of insulin from the mother's uterus itself. So that is where the origin of PCO happens. There is obviously a wide variety of genes. There is a GWAS, so genome-wide associated studies done for PCO, wherein around 200 plus genes have been identified which are linked to PCO. Although we don't need it clinically, but you should understand that this syndrome is 30% genetics and 70% epigenetics or environment, our lifestyle. Okay. So therefore, when a patient says that, no, it's in my genes to become, to gain weight and to become, to have PCOS, you always insist her that it is only 30% genetic and 70% of how you live your life. So it's very important to make lifestyle changes. You can just have a picture of this. This is a short list of important genes which are associated with this syndrome. We'll not go into details, but try to understand that starting from ovarian theca cells to the endometrium, to the follicular development, everything is affected by these significant genes, although we do not do these studies routinely. Okay, so this is a summary of the causes: environmental factors, diet, lifestyle patterns, and obesity. Those are common causes of having PCOS. Okay, so this is a summary of the environmental disrupting chemicals that we are coming across as such in the environment and in our diets as well, and the different organs across the body which are linked to this syndrome. So we can very well understand that this syndrome is much beyond ovaries. Okay, it involves multiple organs. This is again a flow chart which shows how important it is. So this is genetic factors, this is intrauterine factors, again epigenetic factors like lack of physical activity, unhealthy diet, environmental factors and toxins, all of it leading to the consequent effects of PCOS. All right. So these are basically same pictures, but very simple, clear pictures. And that's why I thought of including these in the slides. Why are these pictures so important? Because you try to understand, even if you're treating hyperinsulinemia and PCO, you need to give a drug which reduces androgen levels as well. Because one cause is a link to the other cause. So when you don't approach the syndrome syndromically from different angles, you'll not be able to help a patient with PCOS. Okay, so this is again a summary of subfertility with PCOS. There is increased LH to FSH ratio. However, please mark that you're not going to routinely do LH by FSH ratio. It is obsolete. You can do a day 2 serum LH, but LH to FSH ratio has become obsolete and need not be tested. Increased androgen levels, increased AMH values, and increased insulin resistance, and the right side boxes show you the consequent effects of the pathophysiologic causes. So this I've put only to show you that the syndrome starts in utero. It carries itself forward to the adrenarche or the menarche stage, that is the puberty. It continues and becomes very significant in the adolescent age group where they come with more of cosmetic features. It goes into adulthood where patients will present with subfertility and irregular cycles, and then it carries its effects also into pregnancy. So a PCO female going into becoming pregnant, you treat, okay, we are dealing with subfertility in PCO, you treat her, you do IVF ICSI for her, she has good blasts, and you do the embryo transfer, but you need to impress upon her the complications associated with pregnancy if she is severely polycystic. All right, so what I do is after IVF stimulation, we collect the oocytes, we make the embryos, we freeze the embryos, I ask her to lose weight, put down her weight by 10 to 15 kgs, and then go for embryo transfer after 2 to 3 months. So that is very important. You tell the patient that once the stimulation pickup and embryos have been frozen, your 70% of work is done. 30%, 20 to 30% work is embryo transfer, although the most crucial step, but you need to do your lifestyle changes and bring down your weight before we go for embryo transfer. Okay. So diagnosis of PCO, I'll not go into the details. All of you are clear. Just have a look at this. So there is a lot of criteria, but if we discuss this in details, we'll actually miss out on the important slides. So these are the 4 phenotypes of PCO. Okay, type A, type B, type C, type D. This was the earlier classification. I've put a recent 2024 classification which has come up. So just remember there are 4 phenotypes of PCO. The most important and the most common one is type A phenotype. How do you remember? Remember the mnemonics HOP. So H is hyperandrogenemia, O is ovulatory dysfunction, and P is polycystic ovarian morphology, right? So phenotype A has all 3 of this. So it is HOP for phenotype A. Remember, phenotype B will be H and O, phenotype C will be H and P, and phenotype D will be O and P. So phenotype D patients do not have hyperandrogenemia. I just wanted to impress you upon that. So there is the most common phenotype is phenotype A. Phenotype A, B, C have hyperandrogenemia. Phenotype D doesn't have hyperandrogenemia. Now this is the latest classification of hyperandrogenemia, the PCOS which I was talking about. This is the phenotypic classification of PCOS. So we start with phenotype. It's same actually, but this is the latest classification which has come in Endocrine Journal of Metabolism. So the trends in endocrinology or some that I've forgotten the exact journal name, but this is the new classification. So what was phenotype A has become, this is the classical PCO. They call it classical PCO. Phenotype B is called hyperandrogenic anovulatory PCO. Phenotype C is called ovulatory PCO, and phenotype D is called non-androgenic PCO, or what is normoandrogenic PCO. I think somebody is scribbling. Okay. All right. So these are again the summary of PCO phenotypes. One take home point here is the more hyperandrogenic a PCO female is, the more metabolic complications she will have. So you can see that with progress from phenotypes of A, B, C, D, the insulin resistance, glucose intolerance, diabetic risk, and other metabolic complications will come down significantly as we move from phenotype A to B to C to D. All right. So this is important. I wanted to impress upon you this point. And the right figure shows OS is oxidative stress. You all are aware of a term called ROS, reactive oxygen species, which is responsible for all sorts of oxidative injury in the body, and LGI is low grade inflammation. So oxidative stress and low grade inflammation consequently lead on to all of this. So I told you obesity, insulin resistance, hyperandrogenemia, immune dysfunction, vitamin D deficiency, and consequently subfertility, all are causes, all are due to inflammation, a chronic low grade inflammation, that is LGI. Okay, so this is a summary of the phenotypes A, B, C, and D. And the journal name is Trends in Endocrinology and Metabolism. I think it's a 2022 or 2023 paper. So this is the latest classification. Now we'll understand the pathophysiology of the syndrome. So are you there?
Yeah, Dr.
Okay.
Lipika, please carry on.
So can you please clear the scribble? Because I think it will come on the pathophysiology pictures. Okay, so
You can
I'll
share
move
again.
forward.
You can share again. It will go away.
So it's okay for me
Switch
as
it
far
off.
as the pictures are clear.
You
Okay,
can switch it
so
off and again
basic.
share. It will be good.
Okay,
It
so
will be
I'll
clear
stop
then.
share and share it again.
And we'll figure out who is scribbling. We'll remove the person.
Just give me a minute, please. Is it clear, sir? Are the slides clear?
Sorry, I was muted.
Yes,
Clear, very
yes,
clear.
Okay.
Yeah. Please carry
Okay,
on.
so
yes,
when we
Claire, we
start
can hear you.
pathophysiology, I always use this chick egg hypothesis because you never know, even I don't have an answer as of yet. So which is the first starting point and which is the connecting link. So this will always remain a strong point in pathophysiology of PCO. However, to sum up the most important, pathophysiological causes, I've already mentioned all of it, but this is in a point-wise form. So it's disruption of the HPO axis, wherein there is an idiopathic hypersecretion of LH, insulin resistance and hyperinsulinemia, hyperandrogenemia, obesity, dysregulation of ovarian steroidogenesis, which makes the ovarian environment predominantly hyperandrogenic instead of being estrogenic. So when the ovarian environment is estrogenic, the follicles actually develop properly. But because of pathophysiology of PCO, because it becomes androgenic, the follicles are not able to develop in a normal manner. And that is the reason for anovulation and subfertility, abnormalities of adrenal steroidogenesis, and the miscellaneous points. Okay, so I'll just give you some crisp points of the pathophysiology. We'll not move into details. It will be covered in the course. However, LH hypersecretion, remember both basal and in response to GnRH stimulation, is a characteristic hallmark of PCO. So where it starts, we never know. Which patient will have hypersecretion of LH, we never know. But I have had patients, multiple patients, where all reports are normal, but the baseline LH levels are very high. My highest LH I have seen in my clinical practice is as high as 45. So what is the baseline LH level we take as cutoff? It's 5. I have seen an LH value as high as 45, as high as 38, as high as 31. Right? So our basic purpose is to bring down LH level. There is no particular drug for that. But when you bring down insulin levels and androgen levels, the LH level will normally, it will normalize gradually. So remember, bioactive LH is elevated in many patients who have, so even if you have a normal LH value, you assume that her LH levels will be high if she has PCOS, because all types of LH molecules are not detectable by the lab. Now, what are the possible reasons for LH hypersecretion in this syndrome? There is increased sensitivity of the pituitary. See, suppose hypothalamus is releasing normal amount of LH, normal amount of GnRH, but the pituitary sensitivity to that much of GnRH is more. So that is why there is more secretion of LH from the pituitary. Increased pulse frequency of GnRH, that is causing preferential LH release. I've already explained this. And there is diminished thalamic inhibition. So what happens is thalamus reduces the activity of LH. So that is reduced in PCO patients. Therefore, LH hyperactivity is significantly seen in PCO. Okay. So this is a flowchart which shows you there is increased release of LH in PCO that acts on theca cell, which causes androgen excess and all the hyperandrogenic features associated with PCOS. Okay. So this is just a summary flowchart. Now we move on to the most significant connecting link of PCO, that is insulin resistance. So I think earlier PCOS, very early as the 1875, where PCOS was called diabetes of bearded woman. Okay, so it was the female actually appeared like a male. So that was how PCOS was named. It was called diabetes of bearded woman. And remember one very important thing, nowadays the incidence of lean PCO is coming up significantly. So both obese and lean PCO patients have to be given an insulin sensitizer. This is a very common question which most of my trainees ask me, that will you give metformin to a lean PCO patient? Definitely you will give metformin to a lean PCO patient. The only thing is that the dose you give in obese will be higher compared to that given in lean. Okay. So there are several target tissues where there is insulin resistance, and therefore the consequences of PCO insulin resistance will be metabolic changes or dyslipidemia. In the liver, what happens? We all know that liver is a synthesis point for all albumin and globulin. So all types of proteins are manufactured in the liver. There is one protein called sex hormone binding globulin. You will frequently come across this name when you read PCOS. So what is sex hormone binding globulin? It actually binds the male hormone level. So because it binds the testosterone, free testosterone level, it reduces the it binds the testosterone and reduces the serum levels of free testosterone. Therefore, the hyperandrogenic features come down. But because of insulin resistance, liver does not manufacture that much amount of SHBG. Therefore, testosterone is not in bound form. More of the testosterone is in free form. And that results in hyperandrogenemia and the cosmetic features of PCO. Okay. We all know there is glucose intolerance or dysglycemia. The pituitary LH pulse also. So earlier we used to think that increased LH pulse is causing hyperinsulinemia. See, insulin resistance is also causing increased LH pulses. Okay, so adrenals are also affected by insulin resistance. So that was what I was emphasizing on. In PCO, every cause is the effect for the other cause. Okay. You can see this picture also. So insulin resistance, hyperinsulinemia, that causes decreased hepatic production of sex hormone binding globulin. It affects folliculogenesis in the ovaries. It increases LH level and consequently all the end effects of PCO. All right. So just similar to sex hormone binding globulin, there is also a reduction of the insulin-like growth factor 1. That is a binding protein which reduces, and therefore the free IGF-1. It's a growth factor. So you can understand, once there is hyperinsulinemia, it is an anabolic hormone. So the female will put on weight. All of the anabolic effects will happen. And that happens through a molecule which is called IGF-1. It is insulin-like growth factor 1. Okay. And that also leads to androgen excess. Now we move on to hyperandrogenemia. So what I call insulin resistance and hyperandrogenemia together, it is twinning pathophysiologic factors. So you cannot say whether the hyperandrogenemia started first or the insulin resistance, but these are called twinning pathophysiologic factors. Okay, and both are equally significant. From this figure, you can understand how important it is to approach both the axes together. So when you're approaching hyperinsulinemia, you have to approach hyperandrogenemia. If you're treating one, the other will again, neutralize the effect of the medicines. So when you're giving an insulin sensitizer, also give an anti-androgenic drug to bring down the androgen levels. Okay. Now obesity, the effect of obesity on PCO and PCO on obesity cannot be overemphasized. It is very, very significantly linked to PCOS. You can see what are the symptoms of PCOS and obesity together. So I'll just tell you this one very important thing, which I have been telling you since I started the talk, is functional ovarian hyperandrogenism. So instead of being estrogenic, which should happen in females normally, there is an androgen excess in the ovarian environment. Okay. So this is what is responsible for the follicular growth arrest. So you should understand that functional ovarian hyperandrogenism is responsible for anovulation in PCOS.
Coming from school.
So can you please mute everyone? I think somebody is talking in the background.
What today? Was it painful? A little. Yeah, but you were very brave, isn't it? You didn't cry.
Can I request everyone to keep yourself on mute, please? Okay, so our purpose for this demo class was to make you understand the pathophysiology of the syndrome, guidelines and all related to IVF will be taken up in more details, but I have slides on the same as well, but I'll just simplify what I've talked till now. So I think you will have a look. I've spoken enough on all of this. So decreased SHBG level, increased insulin level, increased androgen level, insulin resistance, hyperinsulinemia and raised LH level. So I think this very clearly depicts what is the, it's a simplified version of this complex syndrome. So genetic, epigenetic causes and all the things which are pathophysiologic reasons for this complex syndrome. Okay, so this is again a triad. I think most of it. Excuse me. Any queries? Please mute yourselves. Okay, so this is a triad of the complex syndrome. I've told you there is preferential release of LH, there is high levels of insulin, and there is excess of androgen level and low levels of SHBG. So this summarizes the syndrome very well. This was what I was talking about, anovulation. Please have a look at the picture. So these are the developmental stages of the follicle from primordial to primary to secondary follicles to Graafian follicle, the egg being released and a Graafian follicle becoming corpus luteum, right? So this is what happens in a normal ovary. Now what happens in PCO is that you have anovulation because of androgen excess in the ovary. Therefore, the follicles will not develop as they normally should and you have a follicular growth arrest. Can you see it's written eggs not maturing and immature eggs are not released. So this is the reason for anovulation and subfertility. Okay, this is again a very important slide on pathophysiology. I'll just emphasize that this I've already mentioned, low grade inflammation. This is gut dysbiosis and this is the twinning pathophysiologic factor of PCOS, hyperandrogenemia and insulin excess. Okay, gut dysbiosis is something which I have a full lecture on that. So you will see when you probe into the history and symptoms of a PCO female, they routinely have some symptoms of the bowel. Either they have too much of flatulence, either they have bloating or they have constipation, they have disturbed bowel habits which affects and disturbs their work throughout the day. So please do not forget to mention about gut symptoms in a PCO female, and when you're treating her, please try to give a pre-probiotic in your prescription. Okay, that will help in alleviation of symptoms faster. So this is again the summary. I'll not repeat the slides, but these are very good flowcharts which will help you understand infertility in PCO. I think this flowchart, this part will help you understand what is the reason for subfertility in PCO. Okay, now we move on to the main segment. Why are PCO females infertile? Okay. So just try to understand. I'll tell you, please have a look at this pyramid. So basically when we are talking about infertility in PCO, no, it is the peak most point of, the pathophysiology and the symptoms. So it starts much below with lifestyle errors, with lack of exercise, with lack of sleep, with altered diet. All of this will result in infertility. But in this course, we'll be covering only infertility, but have a look at the pyramid. So there is a lot to cover. Probably you can have a look at the immunological disorders here as well. And that is the reason we have kept a talk on reproductive immunology, an entire session in this course on IVF. It is very important to approach IVF cases immunologically as well. You'll understand in that session. So this is the endocrine milieu in PCO. What happens to the ovaries in PCO? You can see there is a raised LH level with normal FSH, increased intraovarian androgen, increased insulin resistance, consequently affecting oocyte quality and ovulation rates. So therefore there is subfertility. This is again known to all of you. I've talked several times in the talk. So there is an excess of androgens in the ovaries. There is a comparative reduction in the levels of FSH. There is a raised level of AMH from the pre-antral follicles in a PCO female. There is an excess of LH and insulin. So this results in a follicular growth arrest and therefore the female becomes subfertile. Why am I several times reiterating this point? Because it's a course on IVF. You should understand, and the patient's first question will be that when my syndrome is polycystic ovaries, why don't I become pregnant? Because all your eggs are immature and they are not rupturing as they should. They are not developing as they should. That's the reason. So this is a very good figure. You keep a copy of this in your OPD, and this makes things very easy to understand, So because the follicle doesn't develop in a manner it should, all the follicles become cystic, and that's the reason for a polycystic ovarian morphology on ultrasound. Okay. I think this I've told several times, the androgen excess and all. Okay, this is a summary of what I've told you already, reproductive impairment of women with PCO. So you can see what happens in PCO. It is a very, very thin line of balance. So you never know with what dose of gonadotropin is she going to respond to stimulation. And when you increase the dose by a slightest degree also, she can simply have a flare-up of follicles landing in OHSs. Okay, so unpredictable response may be slow. There may be hyper response, and there is always risk of cyst formation when you stimulate a patient for IVF ICSI. Okay. Now, what are the causes? So I've already told you everything. This is again a summary, the list of causes for subfertility in PCO: anovulation, hyperandrogenemia, insulin resistance, follicular development arrest, obesity and metabolic syndrome, adverse effects on oocyte quality and endometrium, and premature LH surge. This is very, very important. This is underrated. However, in many PCO patients, because of already baseline higher levels of LH, they have a premature LH surge and you lose out on oocytes. Okay. So this is a plethora of causes which causes infertility in PCO. Now, what are the challenges then? Why is it so important to discuss this topic separately? Because it is always a big challenge to choose the right dose. Like I was telling you just now, you start with a standard dose looking at her age, AMH, BMI, weight, everything. But what happens, you never know how she'll respond to that standard dose. Predicting response to stimulation is always a confusion. Follicles having varied FSH threshold. So you never know, all the follicles will look similar, but they will have a different FSH threshold to respond to stimulation. Hypersecretion of LH depletes oocyte quality and depletes endometrial receptivity, hampering implantation and pregnancy. Okay, detrimental effect on endometrium and oocyte quality, and preventing, predicting and managing OHSs has always remained a challenge, especially for this group of patients. So this is, the difficulties we encounter in dealing with subfertility management in PCO. So these are the good references, simple references. We have a series of expert modules from the PCOS Society of India, where one of the modules is dedicated to infertility and PCO. This is freely available on the net for download. You can go through this. Okay, and these are the papers which I had gone through to prepare for this talk. Now we move on to guidelines proper. So if you just write management outlines of PCO on the Google, you will get this flowchart first. So one thing you can see that the first line of management of infertility in PCO is lifestyle. So one of my mentors always used to say the top 3 management criteria for PCO is lifestyle changes, and lifestyle changes. So until and unless she loses weight, even if she is lean, a obese patient will be advised to lose 10% of her baseline body weight, but a lean patient has to lose at least 2 to 3 kgs to have a good result in stimulation or induction. Okay, then we have ovulation induction drugs along with insulin sensitizers and anti-androgens. Then you have either gonadotropin stimulation or you have laparoscopic ovarian drilling, and the third line management is IVF ICSI. Okay, so what are the indications? Because this course is on IVF, so I will emphasize on what are the indications of going for artificial reproductive techniques in PCO. One is failure of lifestyle changes. So she has been trying from several doctors' prescriptions to lose weight, to make diet changes, to lose her weight, but it's not possible at all, because most of the people now come from the IT sector. They have night shifts, they sleep at 3 a.m. in the night and they wake up at 11 a.m. in the morning. So it is very difficult for them to lose weight with this sort of lifestyle. Failure to conceive with 4 to 6 ovulatory cycles. So you have used clomiphene, you have used letrozole, follicles are being formed, they are having ovulation, but still they are not becoming pregnant. associated male factors, tubal factors, and endometriosis, failure of laparoscopic ovarian drilling. Please remember, laparoscopic ovarian drilling is not mandatory for all cases of PCO. It has now become a near obsolete procedure, but there are absolute indications where you should go for laparoscopic ovarian drilling. In those cases, after doing drilling also, if she's not conceiving, please think of IVF-ART, increased female age and lesser scope for conservative approaches. And in case she has some genetic issues in the past, or running in the family, or a bad obstetric history, or repeated implantation failures, and you need to do a genetic testing for embryos, then you go for IVF. Okay. So, the talk will be incomplete if I don't put a slide on lifestyle changes. So have a look at that. Weight reduction, diet and exercise will be number one. Metformin and other insulin sensitizers. Ocipil pre-treatment to synchronize the follicles. It is a topic as such in itself. We'll not go into the details. And adding adjunctive therapies. They are add-ons to reduce inflammation and to exacerbate follicular growth. So I will just show you this picture which summarizes the entire lifestyle changes, and you keep a copy of this in the OPD as well, so that you advise your patients, give them a copy of this so that at least you summarize all the lifestyle changes for them. All right. Now, how do you assess and treat fertility? I will just like to confess that there is a guideline, 2023 International Evidence-Based Guideline for the Assessment and Management of Polycystic Ovarian Syndrome. I'll share this in the group as well. It is freely available for download, and every guideline has been taken from this line by line. So I will not read out the guidelines, but you can have a look at the guidelines. I'll just touch certain highlights. Okay, I'll run through the slides, and whatever thing is important we'll discuss. So this is important. Remember, letrozole is the first line ovulation induction drug for a patient of PCO. Just remember, before using clomiphene, try using letrozole. But I would like to emphasize that I have seen many patients being resistant to letrozole and responding to clomiphene. So where you feel that there is letrozole resistance and letrozole is failing, please try with clomiphene before you move on directly to IVF. Okay, but letrozole is the first line drug. Remember that. Always emphasize on using lifestyle changes, insulin sensitizers, and drugs to bring down her androgen level even when you're stimulating her for IVF. That's very, very important. So add a metformin to all prescriptions of PCO. I will just tell you a few points about the dosing of metformin. So for a lean patient with PCO, just remember, she's more prone to have hyperstimulation. So when you give metformin to a lean patient, start with 250, go up to 500. You can go max up to 850. When you're dealing with an obese patient, please start with 500 BD. You can go max up to a dose of 2000. Doctors go up to a dose of 2500, but I've seen severe bloating with 2500. The maximum daily dose of metformin that I have used is either 1500 or 2000 in very rare patients. Okay, who can tolerate 2 grams, you can go up to 2000 milligrams. All right. So I'll just touch important things. Inositol is a very, very important add-on when we discuss pharmacological treatments. I think it's not in the IVF purview of this course, IVF course, but inositols are very, very important. Please remember, you may have several patients who are severely intolerant to metformin, and their inositols can be a good insulin sensitizers. Myo-inositol metformin combination is the best, but if you find your patient not responding to metformin, inositols can also be an insulin sensitizer, and it is a second messenger molecule which reduces insulin resistance in PCO. So never hold back from using inositols and anti-obesity drugs, even when you're stimulating her for IVF. Okay, tubal patency testing, this is a must if you're going for IUI cycles, but if you're doing IVF, obviously tubal patency is not important. Gonadotrophins, you can decide what dose to use depending on the age of the patient, the BMI of the patient, and the antral follicle count, as well as AMH. Okay, so it's very, very important to use a standard dose, starting dose for stimulation. I think ma'am will take the lecture detail on which protocol to use in which patients. But obviously, I would tell you, if she is average weight, please start with a maximum of 225 international units overall. Like you can go for recombinant FSH 150 units, and highly purified menotropins, HMG 75, but a total dose should be 225 along with a ovulation inducing drug like letrozole. If she doesn't respond on the day 6 scan, you can increase her dose, but you cannot start too high. You never know if she'll hyper respond and land up in OHSS. OHS is again a separate lecture in the entire course. So these are gonadotrophins. LOD, I'll tell you the indications later on. Remember, lean patients are more resistant to therapy, and those are the patients where you go for LOD, and with high AMH, where you see stimulation doesn't result in follicular development no matter what you do. Okay, I'll just tell you a take-home point here. Please do not refrain from using a low-dose steroids when you're going for ovulation induction or IVF stimulation in PCO patients, because I've already told you there is an androgen excess in the ovaries in PCO patients, and you all know that if you give a low-dose steroid from outside, the intra-ovarian androgen synthesis will come down, the resultant ovarian environment will become estrogenic, and therefore there will be successful ovarian follicle development. Okay, I have seen in my clinical practice, even if I add a low-dose dexamethasone 0.5 milligram from day 7 to day 14 of an induction cycle, or from day 2 to day 10 of an IVF cycle, the follicular development significantly becomes better. Okay, so please keep a note of this. You should use a low dose steroid which will not have any side effects at all. Rather, you will bring down her androgen levels and improve her stimulation results. Okay. So what is the ideal protocol of choice for PCO patients? Obviously, it is an anti cycle. It's a gonadotrophin stimulation with an anti cycle. So choice of protocol is anti for a PCO. You cannot use an agonist cycle for PCO patients because they are already hyper-stimulated. All right. I think this I'll skip. In vitro maturation is, yes, it's an option. I have very, very less experience. I have not done much of, I think I have 1-2 cases I would have done in my entire duration of practice. So in vitro maturation, I think sir is a better person to talk about this. He would be experienced, like what are the results, but I'm not very content with the results. So what happens is this, because of improper follicular development and slow follicular growth in PCO, sometimes what happens, we pick up the follicles before they become completely mature, and in the lab you try maturing them with a separate media which is available, that's called IVM media. So there the eggs grow into matured state, and then IVF for ICSI is done. So but I'm not very content with the results, and I don't have much experience with this. Now, the complications of ART in PCO, ovarian hyperstimulation, there is an entire separate session and lecture on this in the course, multiple pregnancies and epigenetic disorders. Please remember that there is a lot of biochemical pregnancy and recurrent implantation failure with a PCO patient undergoing IVF. Sir will also agree that the blastulation rate is very, very low. Everything will appear normal. I have had experiences of having 80 oocytes picked up on the OPU day from a PCO patients and only one blast being formed. So, that is the worst you can think for a patient after spending so much. You collect a lot of oocytes, but embryos are not formed only because of the hormonal impact and the epigenetic changes of these bad oocytes. And very commonly, you will see that PCO patients will conceive IVF, embryo transfer, urine pregnancy test will come positive. When you go for a scan, she'll have a blighted ovum or a missed abortion. Okay, it means that the oocytes and the blasts were not good epigenetically. Therefore, they could not implant. And one more point to remember is that the endometrium in PCO also has a significant altered receptivity. So that we have an entire session on reproductive immunology just because of this reason. You need to understand that for a pregnancy to happen in a lady, her endometrium has to be perfectly receptive and her blasts need to be very good. All right, so these are the only two things which is in our control. But PCOS, I've already shown you, there is also immunological changes in PCOS, and therefore the receptivity of endometrium is also significantly affected in these patients. Now, one very, very important thing which probably is never covered about PCO is the endometrial receptivity in PCO. This, one of the trainee doctors in one of the last training which I had conducted in March, the whole day was on PCO. So one of the doctors told, you've not covered endometrium on PCO, endometrium receptivity in PCOS. Then I made these slides and I thought of giving you an impression. Please have in mind that endometrium receptivity is not normal in PCO patients. All right, and what we need to do and why is it like that? So women with PCOS, it often shows a non-receptive endometrium in ERA tests. If you're doing ERA, I'm not doing ERA routinely, but if you're doing, you'll see a non-receptive endometrium report and therefore consequently implantation failure, right? Now, what are the problems faced related to endometrium? There is refractory thin endometrium. Any of you who is practicing IVF, who has been doing IVF for a few years now, will agree that despite doing everything, you give a good dose of estrogen, you give good angiogenic factors, you give good anticoagulants, you give ecosprin, you give everything, you give arginine, but still there is a refractory thin endometrium. The endometrium does not form at all. There is breakthrough bleeds. You will give medicine, she's on estrabet, again she'll have breakthrough bleeds. So you cannot proceed forward with a frozen embryo transfer. RIF is recurrent implantation failure. I've told you, biochemical pregnancies and implantation failures. Recurrent IVF failures, again, very, very important. Embryos will look good, but she'll not become pregnant. Everything will be good. Endometrial thickness will be good. Vascularity will be good. Blast will be of good grade, but she'll not become pregnant. Okay. Biochemical pregnancies and early and late pregnancy complications. So I was just telling you that the complications of PCO are carried forward to pregnancy as well. So your duty doesn't end after giving her a pregnancy with IVF. Okay. It continues into pregnancy complications because she's already a little bit obese compared to the general population generally. So she is always at risk of having a lot of early and late pregnancy complications. So this is all about the data that has been collected related to endometrial complications in PCO. So this is from a paper. Basically, I've taken the conclusion slides. I'll not talk much about it. Please have a look at this picture. Very, very important. This is a paper from Dr. Deepak Modi. He includes this picture in all of the slides. You know, this is PCOS-related endometrial dysfunction. So these are the several, like pathways in which the endometrium is affected in PCO. And therefore, consequently, the receptivity is very low in PCO patients. Okay, this is again the same picture. So there is a subclinical inflammation which will reject the embryo. There is cell cycle disruption. The mitochondrial dysfunction will be there. Endometrium will consequently not be receptive at all. So there is defective decidualization. You all know that decidua is the endometrium which is prepared itself for pregnancy. So here there is improper endometrial preparation to receive the embryo. Therefore, the IVF, the frozen embryo transfer, does not end in pregnancy. And one very, very important thing which sir was just telling, and we have included this, probably this is one of the first courses where immune dysfunction and reproductive immunology is being taken up because it is very, very significant to give you positive results in IVF. So this immune dysfunction is also seen in PCOS. Okay. Now, what could be the reasons then? We know endometrium is bad, but what could be the causes? ROS levels are raised. ROS is oxidative stress. ROS species, obesity is associated, high uterine artery PI. So even if you give vasodilators and angiogenic factors, the uterine artery pulsatility index, the resistance index and the PI is very high. Therefore, the endometrium does not get as much blood supply as it should get. So routinely I add, some angiogenic factors and a vasodilator like arginine or a nitric oxide donor, which will try to improve the blood flow to the endometrium. Abnormal spiral artery blood flow, you all know this is associated with gestational hypertension, pre-eclampsia, preterm labor, and all of the consequences of pregnancy. Insulin resistance could be a cause. Hyperandrogenemia could be a cause of endometrial receptivity being subdued in PCO. There is significant increase in levels of inflammatory markers, E2 and P4 levels. So estradiol and progesterone levels cannot be well monitored and ascertained in patients with PCO. Okay, and immune dysregulation. We'll go into details. The entire session is dedicated to immunology. So this is again a flow chart, very, very important. So you can understand how significantly endometrium is disrupted in PCO. Okay, so these are the causes. Please, if you want, you can take a picture or you can go through the recording later on. This is again a picture, same picture, but lot of it has been included, and it is from this very good paper, Mechanisms of Endometrial Dysfunction in PCO by Palomba et al. In 2021. So this is available for free download as well, but this is a very good flow chart. This is again how significantly obesity and PCO is associated with endometrial alterations in PCO. This you can see. Okay, so endometrium is completely affected in PCOS. Therefore, there is lack of receptivity, there is defective decidualization, there is increased inflammation and immune dysregulation, and therefore, even if you transfer the best quality embryo in a visibly best endometrium, you cannot ascertain the receptivity, especially for PCO patients. Okay. This is again the same thing, obesity, PCO link, the vicious cycle, and that affects the decrease of endometrial receptivity due to all of this. That was what I was telling you. So insulin resistance, hyperandrogenemia, inflammation, and then consequently leading on to endometrial receptivity alteration. So this is an entire topic I will take in the immunology session. So you have slides on implantation. You can understand that the implantation is again very, very significantly affected in PCO, and therefore you have chances of recurrent implantation failure in PCO. Okay. Now, how do you approach? Okay, we understand that endometrium will be altered in PCO. We understand why the alterations will be there. Now, we should understand what we should do for altered endometrium. So, what I routinely do in my clinical practice is anticoagulants, antiplatelets, blood thinners, and vasodilators. Please add a pre-probiotic to a prescription of PCO, even for an IVF stimulation. Low dose steroids, I've already told you. Immune modulators, you will understand what are immune modulators after we complete that session. Intrauterine PRP and GFC infusion. PRP is platelet-rich plasma. GFC is growth factor concentrate. You continue with insulin sensitizers and anti-androgenic drugs, please. This is very, very important to impress upon you that you should not stop metformin while on IVF stimulation, because you need to continue those drugs in order to improve the oocyte quality and positive lifestyle changes. I think this should be marked in red. So this is very, very important for having a good endometrium in PCO. Okay. All right. Now, this is probably what I have been practicing. So we are even the delegates present today, you all are from different geographical regions. So guidelines are formed. There are several n number of guidelines that you get related to every aspect of PCO. But the problem is that the guideline based population and the clinical population you get in your OPDs are not similar. So please use your clinical experience whenever you're dealing with a patient, your subset of patients. Suppose I talk about India, North Indian patient profile and South Indian, Eastern India is not same. So whatever you gain out of clinical experience, till you do no harm, please try prescribing good medications to patients and see the result. That is how I have started immune modulators and pre-probiotics. Okay. So it is out of my clinical experience. So n number of clinical evidence points even do not carry as much weightage as your clinical practice points will carry. So please remember this. And the summary is to being a doctor, you should individualize every patient. So no second patient coming to you in the OPD is similar to your previous patient. So please approach the patient as per her symptoms, and please write your medications according to that particular case. So individualization of patients is the key. Now summarizing things. This, I think all of it has been told. I'll not read out the slide, but I think you will agree, lifestyle and dietary changes. So it should be a multidisciplinary approach. Whenever you need help, talk to your endocrine friends, because you cannot do it all alone. Sometimes you need your psychiatry friends as well. Letrozole is the first line ovulation induction drug. Add insulin sensitizers, inositols, etc. Add antioxidants. Letrozole or CC can be used. Day 2 LH levels, do not forget to do. I've seen n number of patients with all their reports normal, but LH levels very, very high. So you understand that she's a case of PCO, and we need to bring down her LH levels before you start, like IVF stimulation. I'll tell you one key take home point here as well. So what we usually do is, if you see a baseline LH level very, very high, what you do is give an antac for 2-3 days. Bring down the LH level and then start stimulation. So you expect a better oocyte quality and better receptive endometrium with the patient. Obviously, you're not doing fresh embryo transfers because you are using antac cycles. But however, remember, bringing down LH level before you start stimulating her for IVF cycle is very, very important. Okay, so chronic low dose step up protocol is the protocol of choice in PCO. Antagonist protocol with agonist trigger. Embryo vitrification should be the rule for PCO patients. You cannot give her a fresh embryo transfer until and unless the case is really that significant for doing a fresh transfer. Please do not go for fresh transfers in PCO. Frozen embryo transfer should be the rule. Luteal phase support is required for fresh transfer in case you do that. And preventing OHSS is very, very important. Okay, so this is, I think I have told you everything. I've concluded. Just remember one important thing: modifying conventional stimulation protocols according to patient characteristics and ovarian reserve in a PCO patient and LH level. That is very, very important. So do not forget this. And also, always expect an unpredictable result in PCO. So expecting the unpredicted is the key word. That's the key statement for a PCO IVF stimulation. So do not forget that. Individualized control ovarian stimulation, freeze all embryos, elective single embryo transfer could help in optimizing the success rate of PCO, reducing stress and anxiety, and minimizing complications. This is a summary flowchart of everything, starting from pathophysiology, management, lifestyle changes, and everything. Okay. So dealing with PCOS related infertility, this is what I have learned over the years. So even if you keep trying, someday you'll get the result. Therefore, the light at the end of the tunnel is not an illusion. The tunnel is. So you will definitely end up lighting the lives of those infertile couples. So keep trying, and we keep learning as well. So I expect to learn a lot from the course, from all of you, from your doubts, because all doubts I'll not be able to answer. Obviously, I'll have to go through books again. So education is a progressive discovery of your own ignorance, how less we know, and it's of no value. What you learn, you have to put into your clinical practice. Otherwise, there is no use of learning so much. Okay. So I will be a mother. So impress upon your patients. Don't let it break you. No matter how hard things get, you will become pregnant. Every time you stretch your faith, God does miracles. So it's for doctors as well, because lot of times I have lost hope. I have lost faith on myself. So that is when God comes into play, and you obviously result in giving the patient a pregnancy. Thank you very much for your patient hearing. I'll be happy to take up queries if any. So are you there? Any queries? I'll just see the chat box. I think few queries are there. Okay, immunomodulators I'll not start discussing today. It is very, very extensive. So we'll take up that in reproductive immunology course. So are you there?
Good evening, ma'am.
Yeah.
Yeah, I have one question. Why in PCO patients, some patients are obese and some are the lean? What is the mechanism of action?
The lean PCO is again a topic in itself. Please remember that all the pathophysiological causes of PCO are similar in obese and lean. So even lean patients will have idiopathic hypersecretion of LH. They will have significant insulin resistance. And out of all the pathophysiology, if two things are very important in lean compared to obese, it is androgen excess from the adrenals, and it is altered cortisol metabolism and androgen excess. So remember, it is very, very important to deal with lean and obese equally well, and the approach mechanism should be similar for both the types of PCO. And when I started my practice 7 years back, what happened is there were 70% obese PCO patients and around 20 to 30% lean PCO patients. But nowadays it's around 50-50 or even more lean PCO patients, because lean PCO patients are not aware that they need to bring down their weight. They are going metabolically topsy-turvy. They don't realize. So when you tell a lean 55-year-old girl or lady to bring down her weight, she'll first smile. She'll tell that I've come to you to put on weight. Why are you telling me to bring down weight? So you have to impress upon lean PCO patients. It is much, much easier to deal with obese PCO patients compared to lean PCO patients. Okay.
Okay,
There is an entire session, ma'am. Actually, the thing is that there are two types of fat. One is the peripheral fat, which is visible outside. One is the visceral fat, which is not visible outside. Okay. What is metabolically more significant is the visceral fat. So when I have screened the metabolic profile and lipid profile of my lean PCO patients, I have seen they have a worse lipid profile compared to obese PCO patients. And routinely never refrain from testing your lean PCO patients and obese as well. Because that gives them a scary report, will help them stick to lifestyle. Okay. So lean PCO patients incidence is coming up.
So mechanism of action is same for both the patient?
Yes, mechanism of action is same. Only the drug doses need to be adjusted.
Okay.
Any other question?
You said, madam, in antac cycle, suppose high LH level is there, so you give antac for 3 days and then you start the stimulation.
Yeah.
So
Yeah.
can we do fresh transfer or not, or only frozen?
Yeah. I'll just tell you the answer. Yeah. So what happens is that with hypersecretion of LH, you will understand that the oocyte quality and the endometrial receptivity, everything becomes worse with a high LH level. Okay. So
Yes.
when you scan your patient on day 2, you find a very, very severe polycystic ovarian morphology. And when you do a baseline day 2 LH, see, lot of clinicians have varied opinion. Not everyone will agree to me. But out of my clinical experience, I would suggest please do a day 2 LH level. When you see it is significantly high, prefer giving an antag or a OC pill cycle before you go for IVF stimulation in the next cycle. That's better. That gives you a better response as far as oocyte quality, blastulation rate, and endometrial receptivity is concerned.
Okay, thank you.
Any other question? So we'll go into line by line. Everything will be, discussed in details when we take up the session on PCO. But PCO is such a vast thing. We cannot cover all aspects of PCO in the IVF course. It's a huge, like I had an entire day on PCO. It was a national level training program for doctors where I covered every aspect of PCO. So things cannot be taken up, but I'll be happy to answer your queries because everything will be linked to your management. So if you have any queries during the session, you can always ask me.
Hello, ma. Hello, ma.
Yeah.
Yeah, I want to ask for a patient with PCOS who has infertility and hyperandrogenism. Are there safe drugs that we give for hyperandrogenism for a patient that is being stimulated?
Yeah, it's a very important question. But throughout the lecture, I think I've told you several times. So see, there are 2-3 molecules like inositols are also anti-androgenic. Resveratrol is also anti-androgenic. So when we go on to management, that's a separate thing which I'll not cover in IVF, but I'll add a slide on add-ons in IVF. Okay, so when you go for IVF stimulation also, don't forget to advise them on lifestyle changes and inositol, other antioxidants, coenzyme Q, whatever possible, to make the oocyte quality better, because that will give you a positive, pregnancy. We ultimately want a pregnancy. She's come to you with infertility. Okay, so never refrain from stopping the pre-IVF drugs. Just you can adjust the doses and tell her to use the drugs at least till the day of pickup, so that we expect better quality oocytes. Okay. Okay, a revisit to the lecture will be done during the course. Any other questions? Thank you so much for appreciating. I know I was a bit fast, but there were too many slides I had to cover. Our purpose of the demo classes is, to create interest in you, to dive into the details of IVF and, generate interest within yourself, so that, most of the things will be discussed again. And when the entire session of 2 hours is on PCO, you'll be getting a chance to ask more of your queries. Any other questions, sir, in the chat box if I'm missing out on something? I think most of it is
People
appreciation.
are asking for a PPT. So you can have a revisit to the PPT when you join the course, and we'll be sharing more material while you take the access to the course.
I think we'll conclude here if there are no more questions. And questions will be welcome later on also. You can put in your queries in the WhatsApp group.
You're part of the demo group, so you can put your
yeah, obviously,
queries
I'll be
in
happy
the
to
demo
answer
group
because
itself.
maybe some questions will crop up later on in your minds. So I'll be happy to answer.
Hello.
Yeah.
Hello. Yeah. Are you
Yes,
still
ma'am.
using metformin as a desensitizer, insulin sensitizer?
Yeah, very strongly. I recommend that and I use that.
Up till when? Up till OPU or ET?
See, metformin is something out of my prescription. All the medications, if they become better, they lose around 10 kgs for a adolescent girl or for a female, reproductive age female. Whenever they ask me which medication will be in the prescription till the end, I say metformin. All right. So when you see that she has had significant lifestyle changes, she has brought down her weight and she's doing well in her life, you can stop metformin. But as soon as you see recurrence of symptoms and she's again putting up weight or she's having hyperandrogenic cosmetic features, you can continue or restart metformin again. Start with a lower dose and progress. You can escalate the doses later on once she gets used to the minimal side effects that metformin has. And one very important thing probably I missed mentioning in the talk was whenever you give metformin, please give it after food, give it with plenty of water and give it with pre-probiotics, so that the associated gut symptoms, the bowel symptoms and the bloating that they feel because of metformin will be lesser compared to without giving a pre-probiotic.
Madam, can we give vitamin D along with in PCO
100%
patient?
vitamin D is an absolute essential in the prescription for PCO. I'll do one thing, ma'am. In the IVF session on PCO, where we go for pathophysiology and all, I'll write a slide on the add-on therapies and essentials for PCO treatment, where even when you're doing IVF in her. So whether you're going for induction cycles or you're going for stimulation cycles, never refrain from using essential drugs. I'll just list few now so that all the confusion is cleared. Never forget giving metformin. Never forget giving inositols, resveratrol, very, very important. Never forget giving vitamin D. Okay, so you would have seen in your clinical practice that there are n number of combinations coming. Lot of companies are coming up with a series of antioxidants. So which one to choose? Please choose the ones with selenium, chromium, melatonin, zinc. All of this is important. Okay, resveratrol is a very new molecule. It brings down androgen levels and insulin levels and also helps in weight loss in PCO. Okay, so if she's financially unstable to continue medications, please insist on using medications till you do the pickup so that the oocyte quality is consequently good. But if she can continue, please continue these micronutrients and antioxidants for quite some time, minimum of 1 year. Okay.
Ma'am, you said that LH level suppose high in PCOS in antag cycle, so antag we should give for 3 days. So should we do fresh transfer or not? I have not got the answer.
Not at all, because in PCO cycles, fresh transfer should not be a protocol. The rule is doing a frozen embryo transfer. The crux for that is you prevent hyperstimulation. Your purpose to prevent hyperstimulation. OHSS is of two types, early and late. So once you do an embryo transfer and you expect her to get pregnant, obviously fresh transfer cycles are not at all good, because LH is not the only factor which is responsible for endometrial receptivity. That was the reason I included so many slides on endometrial receptivity in PCO. So by giving antags, you are bringing down the LH level, but there is no guarantee on approval of the endometrial receptivity and preventing OHSS, because still she has that many number of follicles, isn't it? So she always has a tendency of developing OHSS. You should not do fresh transfer for PCO patients until and unless there is an absolute necessity. Okay, I
Madam,
think you can list. Yeah.
Yeah.
one of my patients, she is obese like 90 kg. We have stimulated with 600 dose. Still, she have only 4 to 5 follicles.
Ma'am, very, very good question. I will please request all IVF practitioners to not to go beyond 450 international units of combined gonadotrophins, please, because there is a line that you cannot push a tired horse. Okay. Sometimes what happens if the response is not good, please don't go in like up to 600 for a PCO patient. It is impossible. Don't go above 300, I would say, for a PCO patient. Okay. If she's not having good, because even if those 4 or 5 follicles which you have got will never have good quality oocytes. So please give a gap of 3 to 6 months, ask her to be patient, normalize her hormonal levels, bring down her weight, again go for embryos like IVF stimulation. I'm sure she'll have better results with a lower dose, much, much lower dose of gonadotrophin.
Okay, thank you.
I think other queries you can list in the
Hello?
group.
Yeah, we can have the query in the group. And Dr. Igvilo, do you want to ask something? Sharon?
Just saying that all PCOS patients, do they have to do antag? Because here, antagonist cycle is quite expensive. So what we do is a chronic low dose of agonist cycle.
I've mentioned that, ma'am. Yeah. Here, what
Yeah.
happens is chronic low dose protocol is the protocol of choice for PCO, ma'am, where very slowly you step up gonadotrophin doses at a very, very small amount, and you like increase doses every 1 week or 2 weeks. So this entire cycle will take a month, 28 days. What happens here is that patients do not have that much patience. Otherwise, chronic low dose step up protocol is the protocol of choice for PCO patients.
Since we are not doing ET, so we can stimulate up to 18 days, right?
Absolutely. You just have
Thank
to,
you.
encourage the patient that her menses in this cycle will be delayed. Otherwise, because you're not going for fresh embryo transfer, you're very correct. Therefore, you can stimulate with chronic low dose step up protocol is the protocol of choice. Okay. But what we commonly do here is the antag protocol with agonist trigger with frozen embryo transfer later on in a subsequent cycle. And
Thank
this
you.
is one take home, that please, before you transfer the embryos, ask her to bring down her weight, normalize her, weight a little bit, at least bring down her weight by 5-7 kgs and then do the ET for a better result. Because we know how strongly obesity and all is linked to embryo transfer results. So I think we can conclude.
Yeah. Thank you, Dr. Lipika. That was a wonderful session. And just to introduce you to some of our very respected trainees today, Dr. Igvilo, she's a very old trainee with us. Dr. Supriya, she was one of my first students and a very inquisitive, very nice trainee. And then we
Yeah,
have,
I can understand from a question, sir. I
yeah,
mean, I'm fortunate to have so many trainees and senior people here.
yeah. And then we
I
have
just
Dr. Sharon also, and she was part of our one of our other courses. I think she was part of genetics course, and they've all been wonderful participants in the whole learning program.
Thank you, sir.
Thank
So,
you, doctors.
yeah, thank you to all, and we're ending the meeting now. You can put your questions in the chat box.
any more questions, you'll have questions cropping up. In fact, I have so many questions in PCO running in my mind all the time. So questions will come up. This is a confusing topic. You build your questions up so that we can discuss when we take up this session in the course proper. So then also we can discuss, right? We will have abundant time to discuss as well. Any question in the chat box? I think, sir, I have not answered something.
Mostly you have answered actually. More or less, they're asking for the presentations and all, which we will
Okay.
be sharing. We'll try to share whatever Dr. Lipika is okay with, comfortable with.
I will share the guidelines with you, the PDF format. Please have a look at the guidelines.
In the
If
group.
you're registering for the course, it will be very, very useful, and the time spent in the lecture will be reduced if you go through the guidelines beforehand. Okay. Thank you so much. Thank you so much. I thoroughly enjoyed talking to you all. So please register for the course so that you have an entire comprehensive idea on IVF. Thank you, sir, for being there the entire evening. Thank you so much.
Thank you so much. Thank you so much. Bye.
Thank you.
Thank you to all, and hope to see you again soon.